Scrub typhus, also known as Tsutsugamushi disease, has been recognized in the medical literature for many centuries, particularly in the regions of East Asia, Japan, and the Western Pacific. However, the disease was first scientifically described in the early 20th century. The causative agent of scrub typhus, the bacterium Orientia Tsutsugamushi, formerly known as Rickettsia tsutsugamushi, was discovered in 1930 by Japanese microbiologist Hakuju Hashimoto. This discovery was crucial in understanding the disease's pathology and in developing treatments and preventive measures. Historically, scrub typhus was a significant illness among soldiers in the Pacific Theater during World War II, which led to increased research and understanding of the disease. The disease has likely been affecting humans in endemic areas for a very long time, but its detailed scientific understanding and documentation are relatively recent. Scrub typhus is transmitted to humans through the bite of an infected chigger, which is the larval stage of a mite from the family Trombiculidae, with the most common vector being the mite Leptotrombidium deliense. These mites typically inhabit areas with dense vegetation and are found in rural and semi-urban regions of Asia, the Western Pacific, and parts of Australia. The transmission of the disease occurs when these larval mites, or chiggers, feed on the fluids in skin cells. If the chigger is infected with the bacterium Orientia Tsutsugamushi, the causative agent of scrub typhus, it can transmit the bacteria to humans during this feeding process. Interestingly, the bacteria are not transmitted through the mite's saliva. Instead, the organisms are believed to be inoculated into the skin through the chigger's feces, which are deposited on the skin. When a person scratches the bite area, the bacteria are more easily introduced into the wound. It is important to note that scrub typhus is not typically transmitted directly from person to person. The primary route of transmission remains the bite of an infected chigger. Scrub typhus, caused by the bacterium Orientia Tsutsugamushi, manifests a variety of symptoms that can range from mild to severe. One of the first signs of the infection is typically a high fever accompanied by chills. This fever is often followed by severe headaches and generalized body aches and muscle pain, which are common complaints among those infected. Many patients with scrub typhus develop a rash, which is usually maculopapular in nature and tends to appear a few days after the onset of the fever. A distinctive and key diagnostic feature of scrub typhus is the development of an eschar at the site of the chigger bite. This appears as a black, scab-like sore and is particularly indicative of the disease. Gastrointestinal symptoms such as nausea, vomiting, and abdominal pain are also frequently reported. Some individuals may experience a cough. In more severe cases, there can be mental changes, including confusion, which is a sign of the disease's progression and severity. Lymphadenopathy, or swelling of the lymph nodes, is common, and patients may also exhibit conjunctival congestion, characterized by redness and irritation of the conjunctiva of the eyes. The severity of these symptoms can vary widely, and in some cases, if left untreated, the disease can lead to serious complications like pneumonia, meningitis, or disseminated intravascular coagulation. Due to the potential severity and complications associated with scrub typhus, early diagnosis and prompt treatment with antibiotics, such as doxycycline, are crucial for a positive outcome. It's important for anyone who suspects they might have contracted scrub typhus, especially if they have been in an area where the disease is endemic, to seek medical attention as soon as possible. Scrub typhus, caused by the bacterium Orientia Tsutsugamushi, is effectively treated with antibiotics, and the key to successful management is early diagnosis and prompt initiation of therapy. The first-line treatment for scrub typhus is the antibiotic doxycycline, which is typically administered for a period of 7 to 14 days. Doxycycline is effective in most cases and helps in alleviating the symptoms and preventing complications. In situations where doxycycline is contraindicated, such as in pregnant women, young children, or in patients with allergies to doxycycline, alternative antibiotics like azithromycin or chloramphenicol are used. These alternatives are also effective in treating the infection and are chosen based on the patient's specific health needs and circumstances. Alongside antibiotic therapy, supportive care plays a crucial role in the treatment of scrub typhus. This includes managing fever and pain with antipyretics and analgesics, ensuring the patient remains well hydrated, and addressing any other symptomatic concerns that may arise during the course of the illness. In severe cases of scrub typhus, where complications such as pneumonia, meningitis, or disseminated intravascular coagulation occur, specific treatments and close monitoring are required, often necessitating hospitalization. In such scenarios, the focus extends to managing these complications effectively alongside the primary infection. For hospitalized patients, especially those with severe disease, there's also a need to prevent secondary infections, which can complicate the clinical picture. This involves maintaining strict hygiene protocols and monitoring for any signs of additional infections. After the completion of antibiotic therapy, follow-up is important to ensure that the infection has been fully resolved and to monitor for any potential complications that might arise post-treatment. Treatment should always be under the guidance of a healthcare professional, who can tailor the therapy to the individual's specific health status and needs. Starting treatment as soon as scrub typhus is suspected is crucial, particularly in endemic areas, as delays in treatment can lead to more severe illness and increased risk of complications.